Of the people enrolled in employment-based health care, 77% of us enrollees have a choice of only one insurance carrier. That means that at the point of sale, the real point of sale in health care, where the individual buys the insurance, the individual faces a local monopoly in 77% of the cases. That situation would not be tolerated in any other sector of our economy. These principles are the principles that have given us the highest productivity in the world in virtually all the other sectors of our economy, and customers need to be in control of both the value and the price of what they pay. So how do we apply these principles to healthcare? That's the great challenge. We need to do two things. It's not that many things that we need to do. We need to have a reasonable way of determining how much total health care we as a country provide. And we need to dramatically increase the efficiency, in economic terms, the productivity with which health care is provided. On the amount of total health care, right now, there are no effective constraints on health care growth. Basically, we can ask for whatever health care we want, and we don't feel the extra costs associated with the additional provision of health care. And doctors are compensated by doing more, so they have an incentive to do more health care. So as a result, we have tests that might do some good, but there's no scientific or evidence-based research that would justify those tests. Or we have extremely expensive procedures which will do some good, but no independent body would determine that the value associated with those procedures was worth their cost. CED's proposal is that everybody should get a basic, comprehensive level of health care. This basic level of health care would include all the provision of medicine that is evidence-based, where there's scientific evidence that it does good, and also where an independent body has determined that the value associated in terms of quality of life with these procedures is worth the cost of those procedures. And then anybody can get more than that if they want. We can get tests where it's questionable whether the evidence would suggest they're useful. We can get expensive procedures because they will do some good if we want it, but we have to pay then the full incremental cost of that additional health care. In that way, we will decide on the level of insurance that we want, and in the outcome of that will then be the total amount of health care that we as a society have decided that we're willing to pay for. That percentage may turn out to be 16% as it is now. It may turn out to be 20%. It may turn out to be 12%. The actual percentage doesn't matter because we will have determined that that's what we as a rich country want, given that we think we're getting money for our value for our money. The alternative to this way of determining the total amount of health care is for basically the government to make the determination through this global budgeting and rationing that we talked about. There is no way for the government to get that right, and so we will have the same dilemma that the European countries have. We will end up with some kind of rationing scheme. Now, to increase productivity, we have to realize that in healthcare, the difference between best practice, the most efficient provision of healthcare we find in the country, and average practice, that difference is 50%. That's the largest gap of any sector in our economy. Such a large gap cannot exist in any other sector of our economy because of competition. The great lesson around the world of the last 50 years is that fair, intense competition is what causes average practice to move towards best practice and causes best practice to get even better. thereby both resulting in increased productivity. In order to do this, there has to be choice at the individual level about the level and price of the insurance that's bought. And that has to be universal, and the choice has to provide a full range. Now, markets with this kind of fair, intense competition are not automatically self-forming. Sometimes they are self-forming, but often they are not. When they're not self-forming, it is an appropriate role of government, in the view of the CED trustees, to structure the market. Healthcare is clearly not self-structuring. We've had the experience now that employers are unable to get together and create and organize this structuring on their own. Therefore, the CED trustees, we have concluded that the government must do this. This is not Medicare for all. We're talking about government structuring the market, not determining the outcome of the functioning of the market itself. That's a private matter. It's ironic that we're talking about a new line between government and markets in both healthcare and finance at the same time. This should be viewed as part of the continued renewal of the U.S. economy. We're not copying others. We're not patching up an old system. Some of the details of the reform in healthcare are going to be groundbreaking, but the principles are the old, tried and true principles that have given us the most successful economy in the world. We want to make sure that somebody's in a position to match value and price, namely we individuals, and that we have competition forcing increased productivity. There's no reason these principles cannot be applied to healthcare. We just need to do it. Thank you.